All right. Well, I'm really incredibly grateful for this opportunity to share my research proposal for my Career Development Award application on smoking and contextual social determinants of COVID-19 disease severity. So first, a little bit of background for why I'm applying for this grant. So my graduate training was in health and lifespan developmental psychology, where I primarily focused on individual differences in the health and well-being impacts of major societal events like the one we're all experiencing right now, and also including the 2008 Great Recession. And my postdoc training and research goals now extend to tobacco use and its health impacts in relation to the COVID-19 pandemic. And so to further develop my research skills in social epidemiology of tobacco use and related health disparities, I'm applying for a career development award that's designed for non-clinical researchers who are seeking training in a new field of study. So why am I focusing on smoking and COVID-19? So smoking is now considered one of the most immediately modifiable factors for reducing the heavy burden of COVID-19 disease. And commercial tobacco use is known to impair lung functioning and leads to more severe outcomes. So for example, several meta-analyses of observational cohort studies show that smoking increases risk for hospitalization, ICU admission, and death. Oops. Oh, sorry. Accidentally bumped something. Okay. It's not letting me go back. But these meta-analyses have also shown that the association between smoking and COVID-19 disease severity is really mixed and heterogeneous. But there isn't a lot of understanding of these mixed findings. And potential moderators that could contribute to this heterogeneity have not been identified. And standard moderators such as age or other individual differences or study design differences do not seem to be contributing to these variable effects. Okay, sorry, the clicker is not working anymore, so I'll go back to the... Oh, now this isn't working. And of course, I'm not a PC user, so this is, let's see if that worked. Okay, awesome. All right. So studies on smoking and COVID-19 disease severity have primarily focused on personal and clinical factors, but it's now clear that social context really matters for understanding inequities in COVID-19. And my proposed research is therefore based on two conceptual frameworks that consider both personal and contextual social determinants of health. And so first, the county health rankings model emphasizes both personal and contextual factors that relate to health behaviors, clinical care, social and economic factors, and the physical environment. And second, the collective resource model proposes that personal and contextual factors interact with each other in important ways to influence health outcomes. And so, for example, more well-resourced communities can support the health of vulnerable individuals, such as those who may have more compromised health due to smoking. And so I'll focus on contextual factors that are supported in the prior literature as relevant to both smoking and clinical outcomes before the COVID-19 pandemic. So first, tobacco retailer density and area of socioeconomic deprivation are considered risk factors, and both have shown to be related to increased smoking heaviness and predict smoking-related disease outcomes, including hospitalization for chronic obstructive pulmonary disorder. And it's also important to consider the role of community protective factors. So I'll be focusing on community well-being that has shown to reduce all-cause hospitalization. And importantly, each of these different contextual factors show variability across different geographic areas. So for example, according to the Spire Center, which tracks tobacco retailer density, in some cities, tobacco retailers are 30 times more prevalent than McDonald's or other fast food restaurants. So based on prior research, my first aim of my research proposal is to quantify disparities in COVID-19 disease severity in relation to current and former smoking status and contextual factors that are measured at the county level. And I hypothesized that current and former smoking status, a higher density of tobacco retailers, greater socioeconomic deprivation, and lower levels of community well-being will predict greater COVID-19 disease severity. And based on the collective resource model, I'll measure the moderating effects of contextual factors on the association between smoking and COVID-19 disease severity. And so I hypothesize, for example, that the relationship between smoking and COVID-19 disease severity will be attenuated or lessened for individuals who live in areas with a lower density of tobacco retailers, lower levels of socioeconomic deprivation, and higher levels of community well-being. So to recap the full conceptual framework of the research aims for the study, this figure helps highlight the two different, the first, the main effect model, and then the second, moderation model. And I'll also be including covariates, including chronic conditions, individual level demographics, and chronic disease status, insurance status, and also vaccination status and other factors that might change over the course of the pandemic. And the data source for this study is the COVID-EHR cohort at the University of Wisconsin-Madison. So this is a multi-site study that's coordinated by the Center of Tobacco Research and Intervention and the Cancer Center Cessation Initiative, and it's funded by the National Cancer Institute. And the cohort includes over 1 million COVID-19 patients from 21 healthcare systems across the U.S. And once patients are identified as COVID positive within each healthcare system, they're entered into the cohort and different discrete data elements are shared. And their electronic health records are extracted in addition to their 5-digit zip code. And there are two types of data elements I'll be focusing on: patient information, which includes sociodemographic factors and comorbidity status, and encounter information, which also includes the patient's smoking status. So in the next set of slides, I'll describe the different data sources and definitions for each contextual factor. So for tobacco retailer density, it's important to note that the US has no standard system for tracking tobacco retailers. So I'll be using previous approaches to identify the top 10 probable markets for tobacco, which are listed in this table here. And then density is conceptualized as the total number of retailers in each county divided by the county population per 1,000. And then socioeconomic deprivation and mental and physical well-being will be derived from different public data sources that comprise the 2021 County Health Rankings model. So socioeconomic deprivation will consist of 8 measures that encompass education, employment, income, family and social support, and community safety. And then last, data sources for physical and mental well-being will include data from the Behavioral Risk Factor Surveillance System, which includes information on percentage of adults reporting fair or poor health, the average number of physically and mentally unhealthy days reported in the last 30 days, and also frequent physical and mental distress. And my analytical approach will first focus on constructing the measures of socioeconomic deprivation and physical mental well-being, and using confirmatory factor analysis to identify the validity of these measures. And then I'll also be checking model assumptions, and also because a lot of these variables are expected to overlap with each other, it's important to measure the degree multicollinearity. And then also descriptively compare the study sample based on current and former and non-smoking status. And then my inferential analyses will consist of generalized linear mixed models, which involves patients nested within health systems. And my outcomes will include hospitalization, mortality, mechanical ventilation, and 60-day readmission. And so I'll use a sequential approach to first test the contributions of covariates. And then in the second model, we'll test specifically the association between smoking and COVID-19 disease severity. And then the third model will test the contributions of contextual factors. And then for AIM2, the additional model will test specifically the interaction between smoking status and each of the contextual factors. So I don't have time to go over each of the limitations now, but I'd be happy to expand on these in the discussion. And so overall, what I am proposing to accomplish with this research proposal is to be able to identify subpopulations of people who are at high risk for severe COVID-19. And also these findings will also draw attention to potential place-based or systems-based solutions for mitigating risk related to smoking and COVID-19 outcomes. And this is especially important to consider as smoking is an increasingly stigmatized health behavior, and that is all too often blamed on individual shortcomings. So I'm hoping to draw attention to systems or place-based approaches to instead help individuals quit smoking. And then in future studies, I aim to replicate and expand these findings to other data sources, including other population-based studies that have better measures of community well-being, because there are some limitations with the measures that I'm using. And I will stop there and acknowledge both my collaborators at the UW Center of Tobacco Research and Intervention, and also the directors and facilitators, Christina, in the Primary Care Fellowship. And I'm sorry for my lack of computer skills.
Well, despite technical challenges, you finished exactly as the timer went off. Very impressive in your timing. So we have 8 minutes for questions.
I'll jump in. So this measurement of community well-being obviously is very a critical factor, and you obviously recognize that the measures of well-being that you've identified so far are really those of individual health.
Mm-hmm.
So a lot of, how many days have you reported mental health illness and so on. So I'm wondering, just to start the discussion about what sort of indexes of community well-being that you might be able to bring in to build a model for community well-being. So have you thought about density of faith-based groups, or density of free clinics, or density of pharmaceutical Walmart or Walgreens or other places where people could get support or help? Any ideas along that line? Could that give you an index of community well-being?
Yeah, especially in regards to density of faith-based organizations or community support organizations, thinking of those. I unfortunately don't have the knowledge of data sources for those, and if anybody here has knowledge of information of those types of community supports, I would really appreciate.
I wonder if charity groups, if there are networks of charity groups, whether you might be able to get sort of information around that. But that's obviously a very important factor. I'm sure that it's going to influence and moderate a lot of the manifestations of COVID. It's probably worth really thinking through that and coming up with some.
Yeah, and I think your point that each of these measures are sort of tackling different levels. So the reason why I focused on the behavioral risk factor surveillance is that it does have county level information that is easily and publicly available. So I think maybe thinking of other data sources that can go beyond sort of these individual level markers of physical and mental well-being. Yeah.
Julie, thanks so much. This is a great inquiry. I was just curious, you know, clearly you're focusing on socioeconomic status. I was curious, I know you can include race and ethnicity, but the question is, why are you collecting race and ethnicity, right? I just didn't know, I didn't know what you're trying to study by collecting that as well. You know,
Right, yeah.
You know, the question is, are you studying structural racism as well? So I just sort of challenge us to think about, we can always collect race and ethnicity, but the question is, why are we doing it? So.
Right, and I think, you know, having a more systems or place-based approach, I think it's important to consider some of the structural factors, other structural and societal forces that are at play in terms of privilege and advantage or disadvantage. And so thinking of race and ethnicity beyond covariate, I think I need to think about that more carefully.
Just curious as to know how you continue to refine your English.
Yeah, Elizabeth.
I always enjoy seeing you present this, and it's been a delight to watch this grow and change, and I'm excited to see you're working on a KO1, so congratulations.
Yeah.
I wanted to pick up on both of these comments. So I think the American Community Survey has religiosity and political affiliation or voting record at some geographic level. So you might want to look specifically at that one, and I'll dig back through my files and see if I'm correct that that is the survey that has that in it. And then picking up on the question about race and ethnicity, I actually think you have an amazing opportunity here to look at how much of the supposed influence of race and ethnicity can actually be explained away by neighborhood disadvantage, by community well-being, by all sorts of other things, perhaps to the point where race and ethnicity have no bearing on these outcomes. It's all explained by everything else that you're, and you have such an amazing data source and such rich information that I think that might be a little bit where that question was going.
Right. Yeah, so
Like you could get there, right? Yeah.
Mm-hmm.
Yeah. And I think that would be really exciting to reviewers at NIH.
Right, and to be able to show that these community and contextual factors are really the more proximal explanations
and just
behind
one other little piece that you might think about too is, would it be worth talking to some members of specific communities about their own observations of what may or may not have made a difference for them, and then thinking about whether or not you have a variable in any of your geographic data sets that you could use for those. I just think sometimes we're in our researcher perspective world, and when we flip it around and ask the community themselves, get some really interesting ideas that might not have occurred to us.
Right, getting a better understanding of what their perspective is on what is protective or harmful.
One more question, or we could go on.
One more question, or going on? Going once, going twice.